All right, happy 2019 to everyone. This is Travis. Jeff is away this week, and we will start with Howard. And should have a cue there to start.
All right. I'm going to show this first case kind of backwards, and I'm actually going to concentrate on anatomy, at least in the beginning. So let me put two images up side by side. So that shouldn't have happened there. Let me just fix that. All right, so the time interval between these two is long, as you can see there. And for the time being, ignore the abnormalities present on the earlier examination. And we'll look at the current examination that shows new findings. So there are pleural effusions, and there are a number of interfaces that are interesting. So the one that I want to concentrate on particularly is this interface here, which is new. So it's a mediastinal lung interface there. There is also, well, there are also interfaces down here, and also in looking at the right side of the mediastinum, there's also abnormality there. So initially, when I looked at this, I usually, if I perceive this abnormal interface and it's new, think of the so-called aortopulmonic pleural reflection. And if this is the aortopulmonic pleural reflection, it's a good location for it. One could argue that perhaps the interface goes a little bit lower than is usually the case. But I think just looking at the frontal projection, that everyone would agree that most of the time this abnormal interface relates to the so-called aortopulmonic pleural reflection and represents mediastinal abnormality. So let me now bring up the two lateral projections, again for comparison. So 2002 and the lateral projection from the current exam. And I'll give you a moment to look at that. As you look at that, I will tell you that if I think there's abnormality in relation to the aortopulmonic pleural reflection, the location of it is here. So it's in the more anterior left para-aortic mediastinum. And I look for an abnormality there that might go along with that. Of course, it's often hard to see abnormality in that location in the mediastinum on the lateral projection of the chest. But I'm hoping that as I've been talking, that Travis can make another observation, or David, in relation to where substantially abnormal opacity is present, and it's not here.
Yeah, it's over the spine and more posterior.
Exactly. Very good. So let me show you now the coronal that I made, and I'm actually going to go from anterior to posterior. So we have the anterior junction line, and now as we go posterior, the place where one would see the abnormal interface, if it was the aortopulmonic reflection, would be here in relation to the aorta and the pulmonary artery. And it isn't there. And then as we go back, we see, oh, there it is. So that is the finding. So I'll go back to the chest radiograph that corresponds with this interface right there. And of course, this is far posterior in location to that. And as I scroll back and forth over here, you'll appreciate how much abnormality is present indeed in the middle mediastinum and then going into the posterior mediastinum. So here is the corresponding axial CT. It doesn't have contrast medium on, but you'll see that there is a very large amount of abnormality. Posterior subcoronal, extending posteriorly, paraspinal, pushing things away, lifting the aorta up. And yes, indeed, that corresponds with the extensive abnormality we see here on the lateral projection. So what is this? Well, context really helps now. This is recurrence of tumor, and I'll put up the history going back there. This person has had multiple lymphoma diagnosed from January 2002 with involvement of multiple locations. She's been treated for that, as you can see over there, and certainly the abnormalities that she had on that chest radiograph back in 2002 was the lymphoma, except it was in different locations. And the pattern of recurrence now is what you see on the CT. So atypical lymphoid cells were present, but she did have a biopsy confirming that this is recurrence of the marginal zone lymphoma up there. So really interesting pattern of tumor recurrence, an interesting location for tumor, but very consistent with lymphoma.
Howard, I think what particularly struck me on the lateral view was the disappearance of the posterior margin of the descending aorta. That, you know, there's something smudging the back wall of the aorta compared to before. So, you know, I would put the bulk of this mass alongside the descending aorta, which the CT confirmed, and it does overlap back to the paraspinal location. But, you know,
yep.
Previously we had a pretty crisp posterior wall of descending aorta.
Yeah, all the structures one likes to see there, posterior wall of bronchus intermedius, opacity representing just the left pulmonary artery, and what you described, all of those things are present there. There's just far too much opacity present there and effacing the usual interfaces one would like to see there. Exactly. So that's interesting anatomy and also interesting pathology over time. Here is a companion case, and this starts in December of 2017, at which time an opacity is present in the right lung, and it was noted and described. That, by virtue of the patient's presentation, at least with respect to the recipient of the radiology report, was ascribed to pneumonia. The patient was treated for that. I don't know that any follow-up was done, but certainly in terms of imaging, no follow-up was done. And now we go forward in time to November of this year. And you can see that it is there. And it is a little larger in size. So this is always an instructive thing. Why does someone decide that at this point in time that's a pneumonia? I don't know. But the only history I got back there was cough. I didn't see any history about productive cough or fever or anything else to suggest that that was community-acquired pneumonia, which of course it isn't. So it is enlarging over a period of time, but over a relatively large period of time. So now I'll show you the CT, and you will see that that opacity is one of many multifocal opacities in the lungs. I'll just scroll through quickly. You'll see that it is multifocal, multilobar. The opacities in some locations are solid, in other locations more ground glass attenuating. The margins between the opacities and adjacent lung are ill-defined. There is a small nodule. And let's see whether we can determine whether there are locations in which patent bronchi are present. Don't think so. So a slowly progressive but multifocal, multilobar process has developed over time. Of course, the presentation now is not that of community-acquired pneumonia. And this turns out to be another case, interestingly, of also marginal zone lymphoma, low-grade B-cell marginal zone lymphoma. And certainly the findings that we see on imaging here are very consistent with the opacities one may see with marginal zone lymphoma involving lung.
So I think this raises an important question, which is how do you guys deal with follow-up of suspected pneumonia? Do you put in your reports when you see a nodular focus of consolidation, follow-up radiograph to ensure resolution, or do you just assume the clinician's going to do that, or what?
Yeah, I can say that I have a very rigid way of trying to deal with that. But because I do have access to the medical record, if the only history I get is cough, and I don't see any other findings that suggest very straightforwardly that this is a young person with fever and cough to suggest a community-acquired pneumonia, then I do two things. One, I don't say it is pneumonia in my report. I describe the presence of the opacity. And then I do often say that it should be reevaluated on follow-up examination, and sometimes I put 4 weeks or 8 weeks, for example. So I'm very circumspect about encouraging a diagnosis of pneumonia when the only thing I know about the patient is, for example, just a cough. And that's commonly what I do see at the clinic. So that sort of answers your question, but not entirely, I know.
Yeah, I'm inconsistent too. Sort of depends on what I think the person is in cancer age group and what the presentation is, whether it's acute, with a fever and stuff like that suggests infection, and the time of year, if it's the infection season. But I'm not consistent. In an older person, especially if there's something that suggests a lobar distribution of pneumonia, that implies the possibility of a central obstructing mass contributing to it, then I will suggest a follow-up. So inconsistent, but
well, I think from what I've researched that none of the societies are very consistent, amongst pulmonology and other societies. But Brent Little did a nice paper in AJR when he was a fellow at Mass General, where they looked at, I don't know, a few thousand radiographs and found about 5% of suspected pneumonia turned out to either be a non-treated pneumonia like TB or malignancy in a few cases. So it's not an insignificant number.
Mm-hmm.
But yeah, I think there's no clear consensus out there. So I think we're all kind of inconsistent in it.
Yeah. But I do have a low threshold for going to the medical record, and I'm pretty lucky that I can often get there. And by the time I read the radiograph, often I can get some information. And if it isn't a very clear-cut sounding history for community-acquired pneumonia in the right age group, I'm very circumspect about making the diagnosis of pneumonia on the radiograph. I'm very comfortable saying even an opacity is present, its etiology is not apparent, and it should be followed up. For example, all right, let me show you this case. This case I've shown before, but I want to show this one again because the next case I'm going to show you is very similar to this. So this is a case of a person that had a left pleural effusion for a rather prolonged period of time. And I'm going to show you a selected series during the course of the patient's initial illness. And as you might appreciate, people quite readily describe the presence of a persistent left pleural effusion. But I will tell you that none of the reports of the CTs that were done, and there are quite a few of them, really honed in on the fact that there is substantial pleural space abnormality in the form of lobulated pleural thickening here in the anterior and basal hemithorax, and particularly here along the paramediastinal pleural surfaces. And certainly when I see that, I'm very concerned about the possibility of malignancy. So this turned out to be a malignant mesothelioma. The diagnosis was eventually made at VATS because initial pleural fluid analysis and even I think a pleural biopsy did not reveal the diagnosis, and that's not unusual. So with that as background, let me show you this next case, which is this one. And this is a similar presentation of an effusion in a previously healthy person. She's female. There's a lot of pleural fluid there. And I will show you now the CT axial. Scroll through that for you. Give you a feel for what that right hemithorax looks like. Atelectatic lung, pleural fluid. It's similar to the previous one that I showed you. The findings here are those you can easily go by unless you're looking carefully and paying attention to the pleural surfaces. So here an anterior pleural surface, for example, and even in the basal hemithorax. And the other thing that I teach now is that it can be very helpful to look at coronal and sagittal. So let me show you the sagittal first, for example. And if we go over to the right side, I think it's often easier to appreciate the extent of the pleural abnormality here involving the anterior pleural surfaces in the basal right hemithorax on that sagittal projection. And I will show you the coronal similarly. If I scroll anteriorly and go to the front, right in front here, you can appreciate that there is very pathological pleural thickening involving those pleural surfaces. So that too is very suggestive of malignancy. And in this person, it just turned out that the actual etiology of the tumor was demonstrated on the CT. This was not appreciated or described, but here is the breast mass. That is the cancer that's responsible for the tumor. So subsequent imaging with mammography confirmed the presence of the mass. And as you'd anticipate, the PET shows all of those findings. A very extensive pleural membrane disease shows the breast cancer. So this is presentation of metastatic disease from a relatively small breast cancer, a very extensive pleural disease. So I always teach my residents, examine the pleural surfaces really carefully. And if there's no ready explanation for the pleural fluid, suggest malignancy, mesothelioma, or metastatic malignancy from elsewhere.
So Howard, another thing that's really helpful in this with a mysterious pleural effusion and no visible pleural masses is to look at a lung window and skim through the minor fissure and major fissures, because often you'll see tiny little nodularity along fissures.
Yeah.
Sometimes you catch it in tangent. This one is not cooperating, but I've seen tiny little pleural nodules on this, on the lung window that really are a clue, again, that it's malignant.
Yeah, that's exactly right. One should look at the pleural surfaces too, and if there's pleural thickening involving interlobar fissures, even more concerning.
I said lung nodules, but actually I meant pleural nodules. Good point.
Yeah.
Another thing that's good for meso is invasion of that anterior mediastinal fat from the pleural surface. So I think on the first case you showed in this series, there was actually some tumor nodules in that anterior fat near the apex of the heart. That I think that is more common with mesothelioma than it is with metastatic cancer.
Oh, I see in that first case.
Yeah.
Yeah, the more one looks, the more you can see pathology here. And the other thing that I look for in this particular context, which this person doesn't have, but if you see those findings, even if you see the smallest lymph nodes in the fat, the cardiophrenic lymph nodes, even more concerning for pleural tumor. Yeah. All right, Travis, those are mine for this week.
Okay, David, do you have stuff?
I have I have a couple.
All right.
So here's a 15-year-old, and he had a rash and had this CT scan. I think I'm showing you the wrong one. Let me show you the correct one. Let me go on to the next case, and if you can put me back on in a minute, I'll pull up the right exam. Right now, It's not showing. Okay, so here's a fellow who had a normal chest radiograph. I think this is back in 2011, nice clear lungs, normal heart size. And then he had a pneumothorax. Now, the pneumothorax was asymptomatic, and that's this month or last month, December. It was picked up because he had some hematuria. So it turned out that he had pneumothorax on an abdominal CT, and it's actually a hydropneumothorax. And this is the radiograph then that we were dealing with. Let me show you his CT scan. Then, I'm sorry, things are not going according to plan here. But let's. Here's a CT of the abdomen on this guy that revealed the pneumothorax, and it also shows the reason why he's got a pneumothorax. He's got all these holes in his lung. They're pretty discrete. Some of them are elliptical, like this one I think is elliptical, and it's also perivenous. Some of them are along edges, like along fissures, and these are along fissures too. And so we had this abdominal CT, and people, it wasn't shown to a radiologist because it was an outside exam, and so people didn't pick up on the fact that this is really a cystic abnormality. It's not emphysema. And so with the, let me show you his renal tumor as well. So here's his right kidney, and he's got this tiny little excrescence here, this little bud coming off of this. He eventually had a contrast series, and this didn't enhance very much. The rest of the kidney did enhance. So it didn't have an intense flush as you might expect with a renal cell cancer. Here's the contrast study, and I can show you that. You can see that this lesion is unenhancing in this. But he does have hematuria. He's got cystin in his lungs that led to his pneumothorax, and he's got a kidney lesion. So we were pretty convinced that he had probably had Birdhog-Dubé. And I hope I can show you his, I think this is the guy. Yeah, here we go. So this, we got a chest CT, talked to the surgeons who were going to do pleurodesis on him. I just wanted to get the rest of the lungs to see the distribution of cysts, and they are basal predominant, sort of mid-lung and basal predominant. He'd not had any previous pneumothoraces before this one popped up in December. And it was drained for a while, it was stabilized, and then it recurred, and then he was sent to the U. He did get pleurodesis. So now we've alerted them to the probability that this man has Birdhog-Dubé. The dermatologists haven't seen him yet to see if he has any characteristic skin lesions. The surgeons, glanced at the skin but didn't look at it with that in mind. And so we don't know whether he might have, the typical fibrofolliculomas on his shoulders and back and stuff like that. So that will be looked at, and he'll probably get a genetic consult as well. And then I think his kidney tumor is going to be worked up with ultrasound or MRI to follow. So here's a case of probable Birdhog-Dubé presented in this man who we think is in his 60s with spontaneous pneumothorax, asymptomatic. So it's possible he's had pneumothoraces before that didn't make him symptomatic, since this round was not symptomatic as well.
Yeah.
And
on a side note, if you don't mind, can you show us, if you scroll through the pneumothorax anteriorly, the little fronds of tissue that protrude into the pleural space? We talked before about extrapleural fat sometimes being dragged in. If you hit mediastinum, are those little fatty projections coming from the parasternal anterior chest wall? A little bit lower there, a couple. There you go.
This.
Yeah, and I think the abdomen and pelvis CT actually showed a nice big fat globule along the left heart border as well.
Okay,
I was thinking the same thing, Howard.
That I'm just curious.
This one down here.
Yep.
Yeah, I think we've got some tethering there. So these are pleural adhesions that are probably tethering some of the mediastinal fat here or extrapleural fat. So let's go back up to the higher lesions. Yes, this is fat you can see being dragged from the chest wall. So the extrapleural fat is being pulled in by these adhesions, pleural adhesions. Yeah, good point.
That was just interesting because we talked about that a couple of weeks ago, how we sometimes see that as a curiosity.
So
yeah, very interesting.
Travis, let me just hang on. Maybe I can Maybe I can rescue this. No, I'm going to have to pull up another CT scan. So if you want to switch, and then we can switch back, I'll show you another case that I have some questions about.
All right. So I've got some interesting things that have come in. This is one of my now favorite catheter cases of all time here. So this is a patient who was transferred here on the 31st, so right before the new year. You can see he has a larger bore right internal jugular catheter, and then this is a left internal jugular. It's actually a triple lumen catheter. You can't tell that from here, but it will become important as this story unfolds. And so it looks like it's in a reasonable course. It's lateral to the aorta, so it's probably in the left brachiocephalic vein. Now, my fellow was on call, and they did a non-contrast study, and you can see it does go into the vein here and goes across midline. So this was the non-contrast study that they were doing, and they were doing this as an angiogram because he was actually having lower extremity ischemia. So then they tried to do the lower extremity angiogram, and you can see on the first timing bolus, there's a tiny bit of contrast getting to the aorta, but not much. They tried again, still no contrast getting in there. And so my fellow who was on call said, well, let's take a look at the chest. And even before they did a timing bolus in the chest, you can see where all that contrast has ended up. And so here they just did a non-con, and you can see it's all extra vascular contrast in the mediastinum. And this they injected through that left triple lumen catheter. So clearly something's happening, and it's outside of the lumen. My fellow called the nurse, and they said, no, this thing was flushing. We know it was working. They were able to inject fluids and get back blood return, but clearly at this point it's migrated outside, and this is all extra pericardial, so it's in the mediastinum. So he ended up going to the OR yesterday. They did an angiogram to treat his lower extremity ischemia, and they decided to do a venous angiogram at the same time. And let's see which one of these. So they injected all three of the ports, or tried to inject all three of the ports, and you can see when they injected the third port, which is the most distal tip, that a lot of the contrast is collecting outside of here. When they injected the most proximal one, which actually was the only one that flushed, it would go only in the veins. So it turns out, if you look at what they described here, was that the proximal port was okay, the middle port didn't do anything, and then it was only the distal port that was extravasating into the anterior mediastinum. So this was a partially extravascular catheter then. So whenever they placed it, I guess they must have just checked with the proximal port and that it was flushing okay. So that was right in the wall of the vessel.
Can you bring up that initial radiograph, Travis? And
sure.
Zoom it? Can we actually see that it is a multi-lumen catheter? And
no, you can't really tell.
No, you can't. It's not a very large caliber catheter, of course.
No, and you can even see over here. I mean, you can't tell that. Actually, yeah, you can see right here it is a triple lumen, because you see right here there's this little plastic triangle, and you can see probably the different small caliber ports there. But it's not like a tunneled large bore like dialysis catheter like this, where you see separate ports there. But yeah, so partially extravascular catheter.
So the tip of the catheter that we see on the radiograph is the most distal port that we're actually seeing the tip of.
Yeah, it's hard to know, right, if it's just like side holes for the other ports. I don't know how this thing is manufactured, right, but it's partly burrowed in the wall there. So
okay. Wow.
All right. This one also came in today, which is something I have never seen before, and I'll be curious to see if you guys have seen this before. And this is an outside radiograph from 2 days ago. This is a middle-aged man who had a hospitalization a couple years ago at an outside hospital where they actually detected this abnormality, but he never got follow-up. And you can see there's an abnormal right mediastinal border. And so when you look at the lateral view, let's see, I think that in this case, it's more an absence of findings that you see either in the middle or the posterior mediastinum. And maybe you can say there's a little bit of increased opacity over the heart. I think just looking at the lateral, on its own, it's really impossible to say there's anything here. But you have this abnormal convexity here. And so going through this with my residents, it looks like it's in the anterior mediastinum. So go through typical lymphoma, thymic neoplasms. He was an older patient, less likely germ cell tumor. And turns out that it is neither or is none of those. And on this, let's make sure I've got the arterial phase. On the arterial phase, you will see that this is a huge thing filling with contrast. And it's hard to see here because of streak, but it's actually communicating with the distal brachiocephalic vein right at the confluence, or you maybe even argue it's in the proximal superior vena cava. And this was an outside study, and they did a delayed phase as well. And you can see there's this huge communication right there with this big vascular structure that's simulating an anterior mediastinal mass. So I'm curious what you guys would call this, because he was transferred with this being billed as a brachiocephalic vein / SVC aneurysm. My colleague Kim was able to find one paper in the literature that looks strikingly similar to this. This is an older paper where they called this a diverticulum of the SVC. And I think I kind of like this as diverticulum more, but I'm curious what you guys think and if you've ever seen this before.
Definitely haven't. No, that is.
This is my very first SVC diverticulum. So does the coronal help figure out its origin? Is it right at the top of the cave, or?
It's in the SVC really, I think, because here I can do a MIP, and I think it is. I think the confluence is higher, so I think it's probably, let's see, the sagittal probably helps too. But I mean, I don't know if it really, obviously makes that much. Yeah. So this is, no, it is the left brachiocephalic vein right there. It kind of looks like it's going into, or it's really near the confluence of everything. But this is the left brachiocephalic vein coming across, and it does look like it's coming off that right before it goes into the SVC.
Oh my word.
It fills so completely with contrast. I keep thinking there's got to be an outflow to enable it to fill this well, because it is sort of delayed enhancement here. It's not emptying very well. The other veins have emptied, and
yeah,
this one is.
That's a good point.
But usually, you think a blind pouch like this is going to thrombose, or it's just not going to stay open like this and fill so completely.
That's a very good point, but I think it's actually a little bit higher attenuation than the right atrium or the SVC. So I think it's just, it's filling slower. That is a very good point, though, David. I don't see anything else there's this small little thymic vein.
Mm-hmm.
Yeah.
So, I mean, it's very interesting. I've never seen anything like that.
Yeah, I know. It was funny, though, because my first year resident, the first thing that was said when we were talking about differential, that she said that you can see aneurysms of the SVC, which was kind of funny. And it turns out, she was right, but I told her never include that in the differential again on the radiograph alone, since this is the first and only one I've ever seen. But,
well, she may be a first-year resident, but she's 103 years old, so she's seen a lot.
All right. David, do you want to show yours? I can keep going, or we can switch back if you're ready.
I'm ready if you want to see this, the case that was missing before.
And then I can finish up with some.
So this is our currently 20 years old, formerly at the time of this imaging, 15-year-old boy who had surgery as an infant for a complete total anomalous pulmonary venous drainage. So that's his only past medical history of note. And then he presented with his skin rash, and he had eosinophilia, and he had this chest CT, didn't have the chest radiograph that we've retrieved. And I think we have predominantly peripheral basal low-grade interstitial abnormality. This is 5 millimeter thick slices. it's possible that this is lung edema because he does have lots of septal lines, but it's also possible that this is an eosinophilic pneumonia. Other people consider this might be a pulmonary hemorrhage of some kind. But what's really striking is the lymphadenopathy here. He's got this massive mediastinal and hilar lymphadenopathy. And in conjunction with all of this. So, he had biopsies of his nodes and there was no malignancy. They didn't make any diagnosis. They did notice that there were a few EBV positive lymphocytes lighting up. And he had a subsequent diagnosis of EGPA. So he's considered to have Churg-Strauss. He was put on inflammatory medications and got much better. His follow-up CT, which is the one that I inadvertently showed first, was a year later, and everything has gone back to normal. His lungs are clear, and the lymphadenopathy is gone. So my question is, have you guys ever seen lymphadenopathy in the setting of EGPA? I was trying to find some cases in the literature this morning, and all the publications, including Nestor Miller's article from the early 2000s or 1998 even, or something like that, and all the way through, everybody says that lymphadenopathy is one of the known features of EGPA or Churg-Strauss, but nobody shows a case of it. And there was one Korean article that was comparing EGPA to ordinary eosinophilic pneumonia, and the rate of lymphadenopathy was 50% for EGPA and only 30% for other eosinophilic pneumonias. So I've never seen anything of this magnitude, certainly with EGPA. And
look at the axillary nodes. Even the axillary nodes are interesting too. That is so
right. Axillary and supraclavicular nodes, and no diagnosis of malignancy was made, and this stuff is all gone now. So axillary and supraclavicular. So he had node biopsies. They thought it was a reactive process. They did notice some EBV positivity. So I don't know, maybe the 15-year-old has got mono and EGPA or something. Maybe the lymphadenopathy is really EV virus, in the setting of mono or something. I don't know. Have you guys ever seen anything like this with EGPA itself?
No, I've never seen that extensive lymph node involvement with EGPA. I'm kind of skeptical that's what he has. I think he's got a lymphoproliferative disorder. It got better.
Right.
And then I would speculate that he probably doesn't have EGPA, because that's the primary finding. He's got a little interstitial edema, a very small amount of left pleural fluid, but the dominant finding is the lymph node enlargement. And no, I've never seen that with EGPA. And of course, not with the axillary disease. So it's fishy. It doesn't make sense that this is EGPA.
So it may have fleas and lice. I think the diagnosis of EGPA has been pretty well sustained in subsequent years and stuff like that. And he's still on medication. He did have a history of asthma going into this, which fits that sort of scenario. And he had this amazing, I think he had 60% eosinophilias and stuff like that. So,
and David, did you say he was 15 years of age when that diagnosis was made? Because EGPA would be very unusual in a 15-year-old, right?
I think so, but you haven't looked at the demographics of that disease. Okay. Well, that's the current diagnosis is EGPA, but I don't think that accounts for the lymphadenopathy either. And it seems to me if lymphadenopathy like this had occurred before with EGPA, it would be retrievable from a literature search, and I could not find anything like this at all. Okay, so we'll leave this as a question mark. Probably two diseases at least.
Yeah.
Okay, back to you.
Okay. Well, this is one where I wish Seth was here, but I will show it anyway. And this is an outside study that just happened to come through today. And so this was the first image that popped up when I was looking at this. This was sent to our tumor board for a second opinion. And I think you can see this is actually an abdomen and pelvis series. And I think you can hopefully see on this very first image the presence of suspicious looking findings in both pulmonary arteries. And you can see that if you window it, it definitely looks like there are pulmonary emboli here. And this gets back to the discussion that we've had a few times, and that Seth is the biggest opponent of, and this is the whole idea that you need to have, that there's a minimum threshold for detecting PE of whatever people say, 150, 200, 250 Hounsfield units. Because this one, if you look at this main pulmonary artery, when I was measuring it today, was only 102 or 103 Hounsfield units, as you see here. But these definitely look like acute pulmonary emboli, and especially here. So,
yes.
Yeah, and this was not detected on this outside study, but it turns out the patient had symptoms, and you can see the date on this. It was almost a month later where they finally did a CT angiogram, and he still has bilateral pulmonary emboli in a very similar distribution. So he clearly had them at this time too. But discussion we were having maybe a month or month and a half ago about where this whole number of 150 Hounsfield or 200, 250 Hounsfield unit thresholds came from. My colleague Kim was able to find this one paper, and this is from the Mass General group from 2005, and this is really the only thing that we could find, and they just say somewhere in their techniques that they say at their institution that they use 250 Hounsfield units as a threshold. And let's see, I can't remember, it's in here somewhere where they comment on it, but then anything under that they consider to be suboptimal here. Yeah, that they said 250 Hounsfield units. But, I had said that, and as Seth had said too, that it depends on other factors too, your signal to noise, the body habitus of the patient. But clearly we have an example here of where even at 100, just over 100 Hounsfield units, you can see the pulmonary emboli. And what's interesting is this was the chest done at the same time as the abdomen and pelvis, and there's a little bit of motion on the chest, where I think nobody would put any significant amount of money on it, but the abdomen and pelvis done at the same time, you can clearly see that there are lower attenuation filling defects. And as two studies in the literature show, PEs should be somewhere in the 30 to 60 Hounsfield range when they're acute. And of course, chronic thromboembolic disease can be higher attenuation, but this is now the lowest one that I have of 103 Hounsfield units where you can still see pulmonary emboli.
So, yep. Is this just bland embolism? This isn't tumor embolism.
No, he doesn't have a tumor. They just wanted a second opinion. He was having some mental status changes, and they thought maybe he had a paraneoplastic syndrome, but nobody ever found a tumor in him. So this is just bland embolism.
Okay.
All right, we'll go to this one. So this is a patient, and this raises a question that I have for you guys that I'll bring up in a second. But this is a lady who came in with a cough and had this incidental left-sided abnormality. And you can see there's this large mass-like opacity in the left lower hemithorax. She's got old rib fractures on the left side. And this is the only radiograph I have. And you can see there's actually a little coil here that's related to this. And you can see the location here. It looks like it's in the fissure because you've got like a triangular termination of it superiorly. And so this is actually a coil embolization that was done for this. And you see this is the angiogram. And you can see a little bit of staining and a little bit of blush from an intercostal artery. So there is a little bit of intercostal flow to this huge mass. But most of it is probably from parenchymal vessels, as you can see that this is a large mass in the fissure. And not surprisingly, this patient had no history of malignancy elsewhere, that this ended up just being a large fibrous tumor of the pleura. And of course, since they most commonly arise from the visceral pleura, it's not uncommon to see them in the fissure, as you see in this case. It kind of has a weird little bifurcation at the bottom, but this is all a well-encapsulated fibrous tumor that they were able to pluck out there. But I've seen a few of these now where patients have had rib fractures or prior trauma on the same side, and I have no idea if it's related or not. But I don't know if you guys have any comment on that, because I don't know. It seems like more than once I've seen this, and I don't know if it's probably just coincidence because patients have rib fractures a lot, but I don't know.
Yeah, I've not heard of a purported association and why that might be.
Yeah, I just thought it was interesting that they were treating these intercostal vessels, since since it arises from the visceral pleura, that often the stalk is, as David always likes to point out, is somewhere from the, from the lung parenchyma itself. But this clearly has a lot of vasculature from many different places.
Well, it may be that because of the trauma, she had some pleural thickening, some inflammation in that. If this thing were adherent to the peripheral pleura, stuff like that, because of pre-existing inflammation, it could have parasitized some vessels as well. It doesn't look as if she's got big intercostals.
No, they're not big. It was just that one on the aortogram that had a little bit of flow into it that they coil embolized. So, and the operative report, it sounds like it came out pretty easily.
Yeah, I didn't see any blending of the costophrenic angle or anything. The other thing was it considered to be benign, so low rate of mitosis?
Good question. So this is interesting. Actually, the pulmonologist or the pathologist actually cited this paper from a pathology paper from last year, where it's not a strictly benign versus malignant thing in this case. They use a risk prediction model, which I thought was kind of interesting, incorporating age, tumor size, and mitotic activity. So that was another thing I wanted to bring up. So good question. I thought that was interesting.
Oh, that's interesting.
So, all right. So just a big fibrous tumor. I'm going to skip that one. Let's do this one. Is not a diagnostic dilemma, but it's a nice example of this, and it's nice to show some just classic stuff too. This is a young woman who back in November presented with fever and bacteremia, and you can see multiple areas of consolidation. And of course, when you see bilateral and you hear bacteremia, you start looking for cavities and cavitary consolidation. She is a drug user, and this did turn out to be staph from intravenous drug use with septic emboli. You can actually see a large vegetation on her tricuspid valve, and that was confirmed on echo. So of course there's a lot of motion here, but this is still much more than you would expect to see along the tricuspid valve. And what's interesting about this one too is it's one of those cases where we do, I think, have some areas of what turn out to be macroscopic emboli. Just like this looks a little eccentric in the right lower lobe, and certainly in the right middle lobe you have macroscopic emboli as well from this. But this is randomly distributed peripheral cavities from hematogenous spread of infection and septic emboli. And so she had a follow-up a few weeks later, and you can still see there's a large vegetation in her right atrium, and you can still see she has these areas of macroscopic emboli there, and starting to develop a little bit of a pseudoaneurysm or mycotic pseudoaneurysm in her right lower lobe pulmonary artery, and you can see it narrows here. So there's some of these we've seen treated with coil embolization. I think somebody else showed one not too distant, that where it was coil embolized when you had that. So she's actually doing better now. She had a tricuspid valve replacement. They're just watching this to see if it continues to grow or not in terms of it being a pseudoaneurysm, but it's been stable so far. So just really a flagrant case of septic emboli from drug use.
And embolized vegetations, wow.
Yeah, and embolized vegetations, yep.
Wow.
And this one, glad I get to show this one. Let me see. So this is a patient who had an aortic valve replacement in the remote past. And let's see, I want to find, there's two radiographs here. And these are actually, I'll show you these radiographs, and I'll let you look at this, because these radiographs, as you see, are a minute apart from each other.
Yep.
801, 802. And, the position isn't even that much different between those two. But if you look at those, and let's see, there may be a third one that is, yeah, and even this one is done on the same day. This was 7 hours. This one was 7 hours before this one. So what do you guys think?
I've watched these valves rock on fluoroscopy. It's really amazing. You can see that they're hinged at one point and then they're just flapping like a door opening and closing.
Yeah, from
But Travis,
dehiscence.
you recently showed the dehiscent valve.
What's that?
You recently showed us the valve that dehisced.
I've shown a couple. I can't remember if this is the same one. Maybe this is the same one that I showed you, but I can't remember. I didn't have it noted that I'd showed you this one, but this is one where, yeah, there's a huge vegetation. Okay, so maybe I did show this one. Sorry.
With the fistula to the left atrium and the right atrium. Yeah, you showed us this one.
Okay, well.
Yeah, that's very.
Yeah. All right. Well, then I'll show it. Yeah,
Sorry,
the radiograph is the fun finding.
Yep.
All right. Well, this one I know I didn't show, but I will show it quickly, and then we'll finish. This is a patient who you can see has a really ugly looking thyroid that's considerably narrowing the trachea. And so this certainly looks like and is thyroid cancer. And they have lymphadenopathy as well. And you can see on this one, as David was saying, looking at the lung windows can often be helpful for looking for pleural metastatic disease. And you can see tons of tiny little nodules studying the fissures in this case. But I think this is a good example just for textbook. You can see now a year later, they have some radiation fibrosis at the lung apices. So they've attempted to treat this with radiation, but you'll see on this study, this is one of the prettiest examples I think I've seen of nodular septal thickening from just lymphangitic spread of tumor. And you can just see how you have these little beaded septae there, and just how it's slowly worsened over the course of several studies. I just show the oldest and the most recent one to show that. But I don't know, Howard, we've seen a couple of recent patients with lymphatic or venous lakes or lymphatic pearls from edema, but I think we sometimes, don't always show just the classic cases that usually produce this, like lymphangitic spread of tumor. So this is all thyroid cancer, but just a really pretty example of nodular septal thickening.
Yeah, very much so. Very much so. Wow.
Yeah. All right, and I'll show one more just to finish off. Let's see, this one. And this is one of those ones that, this is a young woman. She's 39. She came in with a unilateral pleural effusion. Of course, in outpatients, you think about, with no history, you think about prior pneumonia with some sort of infected or parapneumonic effusion or maybe empyema or cancer. And she didn't have a history of malignancy. She's fairly young, so you hope it's not malignancy. She has a few mildly enlarged lymph nodes here in the mediastinum. And when you look, I was actually worried because I thought there was maybe a little bit of nodularity developing in the fissure on this study. And of course, this is a PE study, so we don't get a great look at the enhancement of the pleura just because we're timing this early. And I think that, as you guys were commenting on earlier, there's a little bit of infiltration of the mediastinal fat here. So there's certainly findings that should worry us, that this could be a malignant effusion, even though she didn't have a primary. I think they did a PET. I don't remember if the PET actually showed anything or not, but they ended up tapping the fluid, and this turned out.
You've shown this before.
Have I?
Yes.
No, this was TB. This is not the same one I showed you last week.
I showed one exactly like this. There was cryptococcus.
I showed you the crypto last week where it was more discrete nodules. No. So this is actually the second case now I've seen where there's a little bit of nodularity. And this was, and they actually did a biopsy of one of the lymph nodes because they thought it was going to be malignant, and it turned out there were necrotizing granulomas, AFB, and it was TB.
Oh my word! Okay.
Yeah. So no,
it looks very much like the one you showed last week.
Yeah, it was, but no, you're right. It is, but it's not the same case. So this one, but I think that this. Let's see if we can get to the pleural space here. But so again, and you can see that there's a lot of there's a lot of metabolic activity there. And this is a more recent one. And you can see, so going to PET here in this case, it certainly looks like it could be malignant disease with subcarinal nodes, right hilar nodes, and right pleural nodularity, and right paratracheal nodes. But yeah, this all turned out to be TB. So,
that is interesting.
yeah. So now 2 cases of nodular pleural thickening. The other one more dramatic than this, but no history of malignancy, and this turned out to be all TB. So.
And the upper abdomen looks okay, does it, Travis? Just curious.
I think so, yeah. Yeah, on the PET, yeah. No peritoneal disease or anything.
Wow, very interesting. Well, you've shown 2 really interesting cases of that kind of pleural thickening that always makes me nervous.
Oh, and it as it should make us nervous, right? But in this case, you know, they eventually made the diagnosis, so.
Very impressive.
So, but yeah, no, I only showed 1 duplicate case that I'm aware of today, so. But, all right.
Now on, if I see pleural nodularity, it's crypto until proven otherwise. I'm going to stick with that.
Crypto or TB, right? Unless there's a subtle mass in the breast, right? Like Howard's case. So, all right, well, that's it for this week. It's 1 o'clock here on the West Coast, so we will reconvene next week.
Thank you very much.
All right,
Thank
guys.
you very much, everybody.
Take care.
Take care, you too. Bye, everyone.